Aloha and welcome to the Grassroots Institute of Hawaii. We're glad to have you on today's webinar, and our subject is Hawaii taxing healthcare to death? We've got a fascinating program for you, but at the outset, what I want to say is thank you so much for taking time out of your schedule to join us today. We want to hear from you, so our format is very simple. I'm going to introduce our panelists today. Each of them is going to share about 5 or 6 minutes from his or her perspective. And then we're going to allow you to ask your questions. At any time, you can write your question down and send it off to Joe Kent, who will field questions and answers a little bit later on. But again, thank you so much for being here with us today. It's a very important topic, and I'm glad you've taken time to be here. I think you all know, we all realize that over the past couple of months, Hawaii has been taking very aggressive measures to, quote, flatten the curve of the coronavirus. And what that refers to is to curtail the impact of the coronavirus on our fragile healthcare system. And one worry has been that Hawaii hasn't got enough doctors to actually manage the crisis. But I think you realize that long before the coronavirus crisis, Grassroots Institute had been one of many voices warning the state about the growing exodus of physicians from the state. It's an ongoing facet of the brain drain, and it's in response to many government regulations. That's given rise to the timely but often ironic question, could physicians become as scarce as toilet paper? Now, no one knows the shortage of physicians, particularly specialists, as acutely as our neighbor island residents. And that's why I'm so glad that 3 of the physicians today on our panel happen to be practicing on the neighbor island. But going back to the question of root causes, could Hawaii's tax system be a reason for the physician shortage? Should doctors and other healthcare providers in Hawaii be given some sort of break from state taxes, such as the general excise tax, all for the purpose of encouraging them to move here or to stay here or to delay their retirement? Those are some of the critical questions that are going to be discussed today by my panelists. And I'd like to welcome them to the program at this time. Scott Grosskreutz is a radiologist in Hilo, and he's in Hilo right now. Welcome, Scott, to the program.
Thank you. It's a pleasure to be here.
Well, we're glad to have you on board. Ed Goodling, a long-term friend, is an orthopedic surgeon who lives in Hilo and practices there as well. Ed, welcome to the program.
Thank you, Kali. Thanks for having me.
Elizabeth Ignacio, who also goes by Lisa, is a radiologist on the island of Maui. Lisa, thank you for joining us today.
Thank you, Kali.
Glad to have you here. And John Dunham is one of our grassroots scholars who has produced tremendous work for the Institute, particularly a recent paper entitled How Hawaii's GET Adds to Island Healthcare Costs. He's up late in New York City on the East Coast. John, thanks for being with us today.
Thanks so much. It's always nice to be in Hawaii.
Glad to have you as a partner in our work. Now, back to the question, is Hawaii's tax system taxing healthcare to death? We're going to open up with Lisa Ignacio, the radiologist on Maui. And Lisa, here's what I'd like you to do as you take the football at this point. Tell us a bit about the situation now with respect to Hawaii's healthcare system, and in particular, its capacity. People talk about a physician shortage and so forth. Is this real? What do you see as a physician in the field? Go ahead and take the next 5 or 6 minutes to address our audience.
Thank you. Let me go ahead and share my screen here, and then we're gonna bring up this talk. Okay, and then we will start the discussion here. There we are. So can you guys see the screen pretty well? Okay, good. So thank you. Mahalo to Grassroots Institute for hosting this panel discussion. Healthcare in Hawaii, we're in the midst of a physician shortage crisis. It has steadily been getting worse. Why is it getting worse? How can we fix it? This is what we're going to explore here in this discussion. To say that Hawaii healthcare is complicated it's an understatement, of course. There are many layers to this system. You know, we have our workforce, we have science, we have market forces, We have the legal constructs that are all playing a part. So it's a complicated discussion, yes. So luckily, I don't have to break that all down for you guys. There's a lot of independent assessments out there that can properly frame our healthcare today in Hawaii. So, why do we do this? Why do we evaluate all these different things? It's because we want to make good data-driven decisions when it comes to, our better access, improved quality, improving efficiency. We do this all for our patients. We want to do it for our most vulnerable Hawaii patients, those who have a low income, those who are uninsured, and minorities. So every year, groups like CWF, the Commonwealth Fund, they put out these scorecards for the 50 states in the District of Columbia. And they follow our state's progress in 47 specific variables. And so how does Hawaii look? The big question, how does Hawaii look? How does our report card look? Well, for several years now, we've looked pretty good, and I say that with a squint and with this asterisk above my head because we really need to look at that a little closer, but the good news is that Hawaii still leads in several of the healthcare rankings. We are up there with Massachusetts and Minnesota, Washington, Vermont, and Connecticut. We're looking good. And what are some of the things that Hawaii is really good at? Well, we're really good at insuring our patients. We have a huge percentage of our state population that has medical insurance, and that's good. In terms of prevention and treatment, we're really good at avoiding ER visits, particularly in our patients over 65 years of age. In terms of our hospital use, we're good at Medicare spending per beneficiary is excellent. And for our Healthy Lives initiatives, we're really decreasing colorectal cancer deaths in the state of Hawaii. So all of this is largely attributable to the quality performance of our Hawaii doctors. And while we're talking about the Hawaii doctors, I want to tell you some other good things that Hawaii doctors do. Our Hawaii doctors are not just healers, but they're really important to our state's economy. They're supporting national and state economics through the creation of jobs, through the purchasing of goods and services, and the large-scale support of our state and local tax revenues. So in terms of economic impact, 3,700 doctors in our state, and we have $8.5 billion in the direct and indirect economic output. This is a report that's put out by the AMA in partnership with the Hawaii Medical Association. You can see that on average, each Hawaii physician supported about $2.3 million in economic output. And it's worth mentioning that Hawaii physicians support about 47,000 jobs, 47,137 to be exact. They're an important part of the state economy. You can use comparator industries like higher education, legal services, home health care, and nursing facilities, and you can stack those all up in terms of their economic output. And their impact is the Hawaii doctors will still produce more jobs than all four of those comparator industries combined. So everything's great, right? Hawaii's great, our doctors are great. Why are we having this panel discussion? Well, we have to go back to that initial analyses to see the widening gap in some 4 general areas and examine a little bit more closely how we have these steadily declining problems in Hawaii. And I apologize for this slide. I know that it's a little dense and it's full of a lot of complicated terminology. But if you look at some of these areas, prevention and treatment, for example, you have, for vaccines, we have more children in the 19 to 35 months age that did not receive their vaccines that they should. We have more central line infections. Under hospital use, we have increased hospitalizations. We have increased readmissions. For our Healthy Lives initiatives, we have more suicide. That's a national problem that all the states are dealing with. But for Hawaii in particularly, we have slowly increasing infant mortality per 1,000 live births. So, remember how I said that Hawaii is really good at insuring our population? Well, one of my Big Island colleagues reminds me that health insurance does not guarantee timely access. Even having a primary care physician assigned to you does not guarantee access. And so what does this all mean for Hawaii? Do we have lazy doctors? Do we have bad doctors? No, we do not. Looking at data, we see, statewide, Maui, Big Island, Oahu, Kauai, these doctors, our doctors, are working extensive long hours. Their schedules are backed up 6 or 8 weeks out, sometimes 3 months, and they're covering an excessive patient load. And are Hawaii doctors bad? No, they're not. Many independent analyses, including Medicare's analyses, show that Hawaii doctors are providing the highest quality of care in the country. So, I'm sorry about that. Let me go back here for this. I just want to finish up on one more comment that I want to say. Oh, why isn't this working? So I want to show that in a complex system, we know that there are deficits. We know that a lot of these problems are multifactorial. But the single most important factor that is a cause of this problem is the shortage of providers, really. If you look at all those metrics on the prior slide, you'll see that, like, why do we have problems with prevention? Well, we don't have enough doctors to help with health maintenance. Why do we have so much problems with admissions? We don't have enough doctors to keep you out of the hospital. Why do we have so many, even if you do get good care in the hospital, why are there so many readmissions? Because you don't have enough primary care physicians to receive those discharged patients and help to follow them and keep them from going back. So I put it to you that the single most important deficit that we have that directly contributes to the erosion of our healthcare here in Hawaii is really our provider manpower. And I want to show you this important study from UH. Thank you to Dr. Wythe and her staff for these most recent calculations from December 2019. This was submitted to our 2020 legislature, and you can see that our supply, 2974, that's 2974 for our physicians, and 3,522, that's what our needs are. If you look at the blue line, it stays relatively flat. You see the red line, it gets higher and higher. The gap gets bigger and bigger. So that has to do with our increased growth, our aging population. And the same report showed that last year, 243 physicians are gone. 152 just left our state, they were practicing physicians, and 91 retired. The statewide physician shortage just keeps getting worse and worse and worse. And bottom line, we are in critical need. We need more physicians, about 830 to be precise. And how are we going to manage that? That is the basic problem that we're dealing with here. And so we have 3,000 doctors, we got 1.42 million of you, and they're still here. And if I may, and Dr. Akina, before I turn the discussion over, I want to definitely give a quick shout out to all our wonderful Hawaii healthcare workers, including my doctor colleagues, because our Hawaii doctors have been heroes far before the appearance of COVID. They're dedicated, caring people. They're continuing to provide care. And that's despite the fact that Hawaii doctors are older. A quarter of our doctors statewide and a third of the doctors on Big Island, for example, have forsaken retirement so that they can take care of patients because there's nobody else there to do it. COVID happened, it's a frightening pandemic, and it's basically uncovered a lot of flaws and weaknesses in our healthcare system. But our Hawaii physicians just keep working. Despite the risk to their own health, to the risk of their, for their families and their livelihood, they have stepped forward, not a moment's hesitation, not a blink of an eye.
Lisa, I want to thank you very much for your excellent presentation. And I've got a quick question for you, if you can answer it very quickly, because I want to get on to Ed.
Sure.
Given the physician shortage that you have outlined, what is the implication for our state's ability to deal with the coronavirus COVID-19 crisis?
Well, that's a question that I think worries a lot of the physician staff, because we're here and we're working, and you might have seen the statistics that 20% of the people who will be positive for COVID and who will get sick will be physicians and healthcare workers. So we're very concerned. We're already in the midst of this shortage. We're doing all we can. HMA is working with the Department of Health and the state to make sure we're shoring up all those holes and that we're networking as much. We can try to overlap with the physicians that we have. But, a lot of people think, we can rely on other physicians to come to Hawaii. It's just simply not that easy. It's hard to get people to come here. So we're doing all that we can to sort of fortify ourselves, to cross-train and overlap and create a network that's going to help protect us during COVID.
Thank you very much. We now go to Ed Gutling, who is an orthopedic surgeon in Hilo. We've been friends for a long time, and Ed has been a strong advocate along with the Grassroots Institute. Ed, give us a more personal perspective here for people who are in the state of Hawaii and how they are impacted by the condition of the healthcare system. And give us a little bit from your own experience. I'm going to let you have about 5 or 6 minutes to do that. Thanks for being on the program. Go ahead, Ed.
Roger Kali'i, thank you. I'm grateful for this time to address my colleagues and everybody watching.
And Ed, just to interrupt, Lisa, can you share your screen again? Because it might have some of what Ed is talking about.
Oh, sorry, I didn't.
Go ahead, Ed.
How do I do that?
So, as doctors, we're trained to be analytic. We're trained to look at symptoms and see where they progress, and keep a track and keep an eye out for these things. Because if we don't connect the dots, then what we call the natural history is that the disease gets worse and you get real sick and people die. So I would like to show you a few dots that should be connected here. Now, personally, I've never lived through what, the force majeure, what the contract attorneys call, an act of God. I didn't live through the 1918 Spanish flu or the Act of Man that was World War II, or grow up in East Berlin with the wall, which is an act of man. But this COVID thing is an act of God and an act of man in the response, and this changes lives forever. So whatever we had as a crisis in our physician shortage before, it's worse now. So let me give you a dot. The first one up is my former colleague and friend who passed away not that long ago, Dr. Dijon Lim. Now, he was a cardiologist, and he came to Hilo. He traveled through here, loved it, decided he wanted to practice here. And he went on to further training, did his cardiology fellowship at Queens. And the program director subsequently said he was the best cardiology fellow they ever had, ever in the whole history of the program. He could have gone anywhere. He came to Hilo, loved it here. And he was actually from Medan, Sumatra, which is down the road from Banda Aceh, where my grandma was born, and my dad was his patient. And they would talk about Indonesia days. It was kind of cool. And he was very devoted to his patients. I remember once I called him late Sunday night. He came in, he was sick. He came off his sick bed, looked like crap, to take care of my hip fracture patient in the middle of the night to make sure she got tucked away safe for her surgery. I mean, he was very devoted. And then one day he came to me, he said, Ed, I'm quitting. I said, what do you mean? He says, I can't make money. I'm losing money. I'm going to be an employee of the hospital. I said, you gotta be kidding me. How can a highly trained, world-class, fully booked cardiologist not make money in Hilo? Well, and the reason is because most of his patients were Medicare and it didn't pay enough. Now, it used to pay enough. It used to be he could make money, but then the cost of living went up. We got the highest cost of doing business in the nation, and Medicare rates didn't keep up, and he got into a negative situation, and he kept losing money, and he went to the hospital. Now, the hospital could afford him, in part because they make more for the same thing he was doing out in practice, and they're exempt from general excise tax, which is a 4.5% hit. Oh, and by the way, we have close to the lowest Medicare rates in the country, and we have the highest cost of living, and then the state taxes us on top of that. So that's one dot. That was a few years ago. After he died, we've had 6 or more cardiologists come to town. They come and go, and they don't stay. We got some more now. I don't know if they're going to stay. Track record is not. And then in the last 6 months, this list you're looking at, this is 26 docs who died or retired or moved away or gave up. And there's another 3 that are part-time. Up here in the third one down is Dr. Frank Hammer, the anesthesia, my colleague, friend. He's 72 years old. He had a heart attack while he was giving anesthesia during a surgical case. Finished the case before he let himself go to the ER. That's him, yeah. Oh, he won the international world deadlift competition in his age group. Second is a bench press at age 70. But anyway, he passed away a week later. Also on that list of docs is Frank Lazaro, anesthesiologist. He came to town. 2 of his 3 kids were born here, loved it, left. He said, I don't feel respected. I don't make enough, and Hawaii's never going to change. And he left. Another one, a Dr. Danny Chung. He came here, had a kid born, left, same reason. Then up there at the top corner is Dr. Ed Montel. He's a gastroenterologist. He came here and he started the endoscopy center for gastroenterologists. The 3.5 docs there. And Ed Montel retired, his partner retired, the half-time guy moved away. They're down to 1 doc, and he wants to retire. They have been trying to recruit a new doc for the last 6 years. 6 years, unsuccessfully. They cannot pay the going rate. What they offer, which keeps them solvent, is not enough to attract someone. So, why don't young docs want to come here? Well, it's quite simple. We work too hard, we get paid way too little. And if you think that the state government or the hospitals are going to fill this void, it used to be a big hole of private practice. Now it's a sucking abyss. You're delusional. You're magical thinking if you think this is going to fill up. I just read that nationally, the GDP is going to be down 4.8% this quarter. And half of that is healthcare. And so they're all trying to stimulate the economy. You know, the president and the federal government's trying to stimulate the economy. What's Hawaii doing? Nothing. And not only are they not stimulating it, they got a 4.5% GE tax on the gross, which we can't pass on to our patients. We're forbidden. Hawaii is the only state in the union that taxes Medicare, one of only 2 states in the union that taxes healthcare at all. And, you know, 32% of our docs are over the age of 65. We keep going because we love it. You know, I love it. But I got a quote from, you know, in one article, I had a quote from Ernest Hemingway, The Sun Also Rises. How'd you go bankrupt? Well, 2 ways, gradually and then suddenly. That's what's happening. And we think about Rambo. Rambo, you know, said, I love my country. I just want it to love us back. You know, that's us. That's us docs nowadays.
Well, thanks, Ed. I love that quote. And before I let you go, let me ask you this. And it doesn't mean I haven't been listening to you. I've been listening to you, and we've had this conversation many times. But it's a little bit difficult to believe for the average person that a high-paid professional, a medical doctor, has low margins, so low that the GE tax can impact their decision as to whether they can stay in business or not. Can you kind of reiterate that a bit? Because there's a little bit of incredulity there when I talk to people about that, but you've seen the reality of it.
Yeah, hard to believe. Now, if you're hanging on by your fingernails, 0.5% makes a difference, let alone 4.5%. That's on top of the gross. Now, I think my colleague, Dr. Ignacio, Dr. Grosskreutz, could speak to this better than I can, but because this has been analyzed, but it is true. Now, bear in mind, you know, if you're a specialist, you're in grade 26. Grade 26 before you make a penny, and you got $100,000, $200,000 in debt nowadays. It's, you know, and you get what you pay for, but you can't expect them to be monks and live in poverty their entire lives. Certainly not if they got a family. They have responsibility.
Well, thank you very much, Ed. Scott Grosskreutz is a radiologist in Hilo, and this issue of the GE tax has really raised your ire. You've been somewhat of an activist in terms of trying to get our state government to understand that they should do what many states have already done, and that is to exempt medical care from the GET. Can you tell us a little bit about the prospects of that? Is it likely that we're going to get a bill in our legislature? What are the pros and what are the cons? What are the obstacles you're facing?
Thank you, Clay. I've been here practicing in Hawaii now for 25 years. And if we could bring up the slides, please. While the shortage has been a major problem for well over a decade, we're at the point now where we've really hit a crisis point. There's been about 12 or more stories in the press recently about the effects of the shortage. Here's an article in Civil Beat from the president of the Tax Foundation of Hawaii discussing, you know, how ineffective we're practicing physicians out of practice. Next slide. The state GE tax is it's the opposite of a progressive tax. It punishes patients for being sick or injured, often when they're unable to work and pay their bills.
And Scott, I'm sorry to interrupt. I just want to give a definition of the GE tax. It's called the general excise tax, which is a tax on all goods and services, and it's about 4.5%. So go ahead.
Thank you for that, Joe. And the general excise tax is combined with the county surcharges, which can bring it up to 4.7%, and that's on gross revenue. So the HMA has determined that probably results in as much as a 15% tax on, right off the top before you pay any expenses at all. It's a major cause of our physician shortage, the shortage of doctors, and the inability to remain financially viable results in the lowest availability of doctors able to take Medicare patients anywhere in the United States. So Hawaii is number 51 behind all other 49 states and the District of Columbia in the number of doctors available to see Medicare patients. And it actually it lowers global tax revenues because there's so many fewer physicians in the state that could be taxed. Next. New Mexico is the only other state that has this side of heavy taxation on healthcare. They've got a 6% general receipts tax. And the result of these taxes is that you cannot bring new physicians into the system. It's very difficult to bring people in. When you go to medical school and you're finished, you're often $250,000 in debt. You're in your mid-30s. You've got to service that debt. So to come into a state where it's basically private practice, which is a small business, and you can't make that a working proposition, that's why we can't get new doctors in to replace us at all. And as a result, Hawaii and New Mexico have the oldest physician workforces in the country. Next slide. Now, a good question is, do hospitals pay the general excise tax? And the answer is no, thank goodness. Hospitals and their employed physicians are not subject to the GET. And according to the president of the Healthcare Association of Hawaii, and this is a direct quote, hospitals overall in Hawaii operate on very small margins. The GET would drive overall margins negative and have a devastating effect on the ability of Hawaii's hospitals to adequately care for the people of Hawaii. The only hospital in Hawaii that recently was subject to the GET tax was St. Francis West, and they were pushed into bankruptcy within 20 months. Next slide. One of the problems I think that we have in the state is that the state of Hawaii just doesn't understand federal Medicare policy. This is a tax fax from the Hawaii State of Taxation, and you'll see in the lower right-hand side, can physicians who are charged the Medicare tax for Medicaid, or the GET tax for Medicare, Medicaid, and TRICARE, can they pass it along? And basically, if physicians, and it says that you can, but if you were to actually do this to basically bill the patient for their Medicare tax, the GET tax, I talked to CMS and they basically said that any physician that does that will be referred to the Inspector General. They're going to require to refund all those taxes. In all likelihood, you could be disbarred or blocked from the federal Medicare programs, and that could result in the loss of your license. So, or your state, your hospital privileges. So to do that would be, it would be suicide. And so I hope no physician is following the recommendations, from the state here on doing this. Now, Medicaid programs, those are a state program, but I don't know of any physician who charges Medicaid patients GET tax. They absorb that as well. We just don't feel it's ethical to charge patients for healthcare when they can't afford that care. Next slide, please. So in order to try to address these issues, we do have a Hawaii Physician Shortage Crisis Task Force. We did meet with Mayor Harry Kim, and the mayor was immediately declared a state of crisis for healthcare access on the Big Island, where we have a 44% shortage of physicians. Every legislature basically on the Big Island has sponsored legislation to exempt healthcare from the GET tax. Representative John Mizuno, who is chair of the House Committee, and Senator Rosalind Baker, chair of Commerce, Consumer Protection, and Health, have introduced legislation to exempt physician services and APRN services for healthcare from the GET. And the good news is that that bill, which is Senate Bill 2542, actually passed the Senate and moved over to the House of Representatives. The House Health Committee assures us that that bill will pass that committee. The real problem is the House Finance Committee, which did not hear the House version of the bill and has not expressed any support for passing GET reform this session. So that's our real challenge and obstacle right now. Next slide. We did have a chance to speak to Governor Ige. He was kind enough to spend the better part of an hour with us discussing the challenges, the COVID pandemic, and the situation that physicians face here. Since the legislature recessed before the GET bill could be passed, we have asked the governor for an emergency or executive decision to exempt healthcare from the GET. And just today, it was announced in the newspaper that Governor Ige said that the federal payroll protection program payments to businesses in Hawaii will not be charged with the Hawaii GET tax. So in effect, what we're asking for healthcare is totally in line with the actions the governor has already taken. Next slide. We also have received support for this bill from the state director of the UPW, and we're grateful for that. Like all of our folks in Hawaii, regardless of how you work, what setting, we all need to have access to healthcare. Next slide. Unfortunately, the coronavirus pandemic is making things much worse nationwide. At this point, before the pandemic, about a quarter of rural hospitals were threatened with closure and were financially struggling. There's major healthcare systems like Mayo that are projecting losses as high as $3 billion. The American Academy of Family Physicians estimate that 60,000 private medical practices in the US will either be closing or reducing services by June, and that those 60,000 practices, they employ 800,000 medical workers. Next slide. This situation, this crisis is going to get particularly bad on the Big Island. As you can see from the population chart estimates there, that Hawaii Island is projected to move from about 200,000 in population to over 300,000 by 2045. And our shortage of physicians is actually, the curve is going downwards. We have less physicians as we have more people to take care of. And by 2040, our task force is estimating that we will have a shortage of physicians that will exceed 700, and that we will be lacking 480 physicians on the Big Island alone to care for the community. Next slide. So it's really critically important that that this GET legislation that we actually helped draft be passed as soon as possible in order to keep physicians still in practice. Once these physicians have to close their office and leave, that it's very difficult to bring them back. With so many physicians over age 65, if they have to basically start tapping into the retirement funds to keep their office open, so it doesn't, so that it doesn't go bankrupt basically in the next few months, then these people will be gone. We've already had reports and spoken to physicians who have been evicted from their medical offices because they couldn't pay their rent on the Big Island. So it's critically important that we keep physicians in practice. The pandemic is a healthcare crisis. In order to deal with the healthcare crisis, you need healthcare providers. And so we're just very hopeful that we can keep these physicians in practice. There is expected to be a second and third wave of the pandemic. In the future, tourism is at risk here. It's our lifeblood of the economy. If tourists do not feel safe coming to Hawaii because we don't have enough doctors to take care of our local community, let alone visitors, they'll go elsewhere. And the other big impact that we can even see here on the Big Island is we see a lot of retirees that love the Big Island, that love living in Hawaii. They often contribute to the community, but they end up leaving once they get healthcare problems because they know that we don't have the resources in place often to provide them with the level of support that they feel they need. So it is a crisis, and thank you for giving us time to talk about this.
Thank you, Scott. That was an excellent presentation, and I wish you well on that bill that will go through, hopefully, when the legislature reconvenes. Well, you've heard it from the physicians in the field. We want to share with you our own economic analysis. John Dunham, president of John Dunham Associates, does outstanding work for the Grassroots Institute, and we'd love you to go to our website and look for a paper entitled How Hawaii's GET Adds to Island Healthcare Costs. It's an excellent analysis of the subject, and I've asked John to share a little bit about the numbers. He's the author of that paper. John, you go ahead.
Great, thank you so much. I feel humbled here with all these physicians. I'm just a lowly economist, so it's a little bit different for me. Can everyone? I hope everyone can see this screen.
Actually, can you share your screen?
I thought I did that. I'm sorry.
Okay.
Go back. Technology and I are not great here. Share screen. Okay. Try that again.
There we go.
All right, we're getting there. So I'm going to just give you some brief numbers that we came up with in looking at the general excise tax and its effect on physicians and the healthcare system in Hawaii. First, I want to say though that a tax like this is what we call a gross receipts tax. It's a tax on the revenues that a company makes or a physician makes. Is extremely rare in this country. There are only 2 or 3 states that have gross receipts tax at all. And most of them exempt a lot of things, including medical care. In the case of Hawaii, there are actually a lot of exemptions on the gross receipts tax. For example, petroleum refining is exempt, airplane leasing is exempt, and also orchards are exempt. So the state of Hawaii finds that orchards are a lot more important to the economy than physicians, I guess, by looking at that as a potential exemption. So what this tax is an ad valorem. It's a percentage tax on all medical services performed in Hawaii and in certain jurisdictions in some of the counties in Hawaii. Even though it's illegal to pass on the tax, what all taxes do is they either raise prices or they lower services that are available to consumers. In the end, consumers pay taxes either through higher prices, reduced services, or in some cases, reduced quality of services. We looked at the tax in Hawaii on the segments that it's imposed upon, and we found that overall it taxes medical consumers and practitioners about $222.3 million. And that's actually a big number when you look at how, actually small the economy of Hawaii is and how, just what the size of the medical profession is. Now and I'm going to go into this a little more detail. We looked at what would happen if the state were to exempt medical care from the GET. And we found that it would create about 3,945 jobs in the medical care industry in the state. Now, these aren't just physicians. These are physicians, lab workers, nurses, administrators in offices, 3,945 new medical jobs in the state, and another 4,000 jobs in industries that supply the physicians and that benefit from sales made to the workers in the healthcare industry. Now, it would obviously reduce GET revenues by $222.3 million, but that would be offset by $67.3 million in new taxes generated on $1.4 billion in new medical economic activity in the state. So it is pretty substantial. Now, we looked at the overall medical industry in Hawaii, and our numbers are slightly different than the AMAs, but not by a lot. We find the direct jobs in medicine in Hawaii in 2018 were about 65,000 jobs. Now, we get this by counting actual doctors in the state. So that's where our number comes from, our doctors in their offices. And of these jobs, about 38,000 are subject to the GET. As was mentioned, hospitals are not. Generally, nursing community care facilities are not because they're nonprofit. And mental health and substance abuse type facilities tend to be nonprofit too, and they're not subject to the GET. Now, the 38,000 people that are subject to the tax generate about $4.9 billion in economic activity in the state. And the state collects about $5,000 per employee from the GET, and the counties that impose the tax, and those are the major counties in Hawaii, receive about $700 more per employee. So if you think about it, a normal physician's office with a doctor, maybe a physician's assistant, and a couple administrators would be paying about $20,000, $25,000 in gross receipts tax to the state. And that comes straight out of the bottom line of that practice. Now, if the tax were eliminated, again, I mentioned about, in total, about 8,000 new jobs would be created. Those jobs would generate about $678,000 in new wages for people working in the state and $1.4 billion in economic activity. It's a big deal. State and local taxes would be offset somewhat. And it would spread out the benefits would spread out far beyond just the medical industry. The table at the bottom of this slide shows that industry is varied as social services, retailing, restaurants. Of course, this was when restaurants were open still. Real estate, the hospitals, which are not subject to the tax, the construction sector would all benefit through new jobs created. That's basically my presentation. This is a tax on individuals in the state, be they the doctors in their offices or the people that are looking for medical care. It's a very odd tax, and I would think that medical care is at least as important as orchards in the state of Hawaii. So possibly this would be a good place to look for an exemption.
Thank you very much, John. And anyone can access your paper by going to the Grassroots Institute website and just typing in John Dunham, D-U-N-H-A-M. Appreciate your presentation. Well, folks, now it's time for questions and answers. And if you haven't submitted a question yet, you still have time to do so. There are many that are on queue right now. A couple of announcements first. Next webinar is on May 15th. We definitely want you to be here with us. We have an expert named Jacob Solom, who is senior editor at Reason Magazine, and he's a columnist for the Honolulu Star-Advertiser as well. You've seen his work on Saturday's edition. He is going to give us a presentation entitled How the CDC and the FDA Wrecked Our Economy. Let me say that again, How the CDC and FDA Wrecked Our Economy. You don't want to miss that. That's May 15th, and that's at noon. The second announcement is this. Today is the soft opening of a petition drive that the Grassroots Institute is launching. It's called simply Let Hawaii Work. If you believe that we should tell our governor and our mayors and our legislature, it's time to let Hawaii work, we invite you to sign that petition. You can do the soft opening today by going to the Grassroots Institute Facebook page and finding the form there and just clicking that. Or you can wait. If you're on this call, we'll email you a link that you can use tomorrow. But in the meantime, go to our Facebook page and let's all send a big message to our government. Let Hawaii work. And now to Joe Kent for questions and answers.
Oh, first thing that, just a correction, the webinar that Kaylee mentioned that's coming up is actually on May 5th. So if you'd like to learn more about that, you can visit our website. We have a lot of questions coming in and keep them coming. We have Keali'i Mossman asks, if doctors can't legally pass on the general excise tax and instead raise prices to try and cover the GET that they have to pay, wouldn't that increase their gross receipts and lead to an even higher general excise tax due?
Yes.
Okay. There's a lot of other people who are asking questions about things that maybe haven't been mentioned. Ed's list, Ed, you mentioned a list of doctors that left or passed away in 2020, and David Griffith says, Ed's list of missing doctors does not include the equal or bigger number of Big Island docs that used to practice in Kona and Waimea, and it's kind of a revolving door of, or swinging door of a lot of them just coming and going. So what are your thoughts on that?
I referenced the list, but I didn't generate it. Yeah, I'm not surprised if there's people not on there, to tell you the truth.
Sure. Also, we have some folks in the audience that I think may have something to say about this. Michelle Mitchell, is she there? Yes, Michelle. And Scott, would you like to introduce her?
Yes, Michelle Mitchell is a member of our Hawaii Physician Shortage Task Force. She has a private practice. We're very glad to be working with her on the Big Island. She's been trying for some time to recruit some additional physicians, and she's been a frequent voice for advocacy for this issue at the legislative level.
Well, Michelle, I think we might be able to hear you. So are you able to give us your take on this?
Sure. First, I can answer the question about increasing prices. I can set whatever price I want. You know, as a primary care physician in Hilo, I can charge $75, $500, $5,000. But I'm only going to get whatever the insurance pays. So the contract with the insurance is that they pay me their set price, and that is what it is, no matter what my price is. So the price that I set only matters for somebody without insurance. which becomes an unfortunate reality for that person. And I can speak to having a great deal of difficulty in attracting physicians to come to Hawaii. I was actually talking with Dr. Ignacio with that earlier this week. It's a big struggle. You know, my practice is overwhelmed with patients. We have a huge shortage here on the Big Island of physicians, and I would love to have another physician in my office. And before we were struggling with the pandemic specifically, I'd been searching actively for another primary care physician to add to my practice. And I'd been looking actively for 6 months. And in that previous 6 months, I'd interviewed 6 different physicians. 4 of them had actually had a connection, strong connection to Hawaii. They'd either lived here or had immediate family members here. And I offered each of those 6 physicians a position here, but not a single one took it. And they all cited an inadequate salary. And it became a problem because I couldn't offer them a higher salary. If I did, I'd actually be paying for the medical care of our community. And I can't continue to do that. And I had 6 people who wanted to come here. They wanted to be here. They wanted to be in rural areas, but they also have bills to pay. They have loans to repay, and they're honestly tired of living in poverty. You know, as a medical student, you are accumulating debt for the privilege of working your butt off, as you know, to learn and working in hospitals. And then as a resident, you're paid minimum wage or less. That's honestly what we get as residents. And it becomes a really difficult pill to swallow, to be continued to ask to live essentially in poverty as an attending. And that is why we're struggling so much to get physicians here. It's not they don't want to be here. It's that we're really tired of living in a situation where we're forced to scrape by.
Okay, thanks, Michelle. That was a really compelling story.
Joe, can I
Go
comment
ahead.
on that real fast?
Go ahead.
Michelle made a really interesting point. She gets paid for, all the doctors get paid for a service by an insurance company who has already, you know, schnurred the price down as much as is possible. So let's take a service that costs $100. The doctor gets paid by the insurance company $100. Now, you would think that the GET on that's what, $5 maybe. But let's see where that $100 goes. First off, that doctor is paying about, of that $100, about $45, and these are real numbers, about 45 of those dollars goes for goods and services that the doctor has to pay for, you know, to provide, you know, to keep their practice going. Things like insurance, things like rent, things like electricity, things like swabs and Band-Aids and you know, needles and things like that. So that takes them down to about $55 out of that $100. Then they have staff, right? They have a nurse practitioner, they have a nurse, they have people that have to manage all that paperwork that comes from insurance. That's going to be about another $25 of that $100. Now it takes the doctor down to about $30. Now remember, the doctor's a small business person, right? So they've got $30 out of the 100. Now they have to pay taxes on that. Average tax about what, a third? Now they're down to $20. So that $100 payment from the insurance company ends up equaling $20 to the small business person, and now the state is going to take $5 of that. So that $100 bill generates for the doctor $15 whole. And that's after what, 24 years of medical school. There's something, it's a 25% tax really when you look at it.
Oh, that's a really great example. And David Griffith in the audience mentions, in terms of recruitment, it's not necessarily just the general excise tax, because you know, there's a lot of other added costs of doing business in Hawaii. Right off the top, it's the lower reimbursement, he says, because of Hawaii's rural status. And also, there's no doubt once a physician is in the system, the general excise tax is a big factor, and you have your overhead increased, as John mentioned. So David says, outpatient clinic overhead can range anywhere from 35% to 80% of revenue. Does anyone want to respond to that?
That's a pretty good number. It's about 75.
That's kind of what it was about what you said. Yeah,
That's
exactly.
about what I said. Yeah.
Right. Lloyd Lim says the legislature may say, Scott, referring to the bill, your data is no longer accurate due to coronavirus events. So your projections don't really mean much. Do you have an answer for that?
Well, we are working with Kelly Withy and others to try to get a more accurate projection of the shortage. But with the loss of hospitals and healthcare workers who are actually being fired from the job in many locations in the Big Island, it could only be worse. And this problem has been looked at and reported to the legislature by the Area Health Education Center of the University of Hawaii for going on 10 years now. And we haven't had any remedial action taken to date. And to be honest, we're in a position where actually there'll be less money coming to the public coffers, because if we were to actually have the 830 physicians that we need in order to provide care for our local population, according to an AMA survey, the average physician pays in $126,000 to state and local taxes. So you just do the math on that, and we could be bringing in, if we had enough doctors and we just tax them at standard rates for corporate tax and our fairly high personal income tax, you'd be looking at another $100 million in addition to the jobs created that Professor Dunham was talking about. So yeah, you're right. The COVID pandemic has changed things for the worst.
Guy Monahan says he's troubled by the exclusion of certain therapies and osteopathic methods, particularly by insurance restrictions and government regulations that are not applied in other countries. And he says that patients just go to other countries then to get some of those treatments. So he was curious about the effect of protectionist measures on restricting the supply of doctors in Hawaii. Are you seeing that?
Well, there are major issues with the supply chain of different providers, and of course I'm knowledgeable about the physician, and I know we're also, in talking to our nurse colleagues, that there's a shortage of APRNs. There was projected to be between 80,000 and 130,000 physicians less than we need to service the healthcare needs of America by 2030. With the COVID practice and people who are going to be bankrupt, retired, sick. Unfortunately, some of our healthcare practitioners are dying. That's going to be worse. And so if you have a nationwide shortage to that extent, and the rest of the states will be actively pursuing the remaining physicians, and they will, our state is basically chasing people away while other states are trying to recruit physicians, getting with medical licensing, requirements in the state, things like that. It's a huge issue. And the other problem that we have is that while there's not enough medical students, there are not enough residency slots available in the U.S. to train the existing medical students. And so you can graduate from medical school and still not be able to get the additional residency training you need in order to practice as a physician. So that's a huge roadblock. So the idea that somehow we're going to lose these doctors and somebody's going to write a law or have some proclamation and we're going to fix our problem, I just don't see that. We have to have Hawaii to be an attractive and competitive place to practice in order to have any shot.
Mark Maniscalco asks, he says, he agrees that we need to exempt medical care from the general excise tax, but he also suggests that Medicare and insurance reimbursements are a major problem for health providers in Hawaii. And he asked, do our panelists have any comments on the Free Market Medical Association and the concept of cash payments rather than third-party payer insurance?
There are some individuals I know that have left practice to become kind of a concierge practice. That is a model that works for some folks, and so we are having some physicians move to that sort of a thing. But particularly on the Big Island, we have a huge percentage of the folks that are in the Big Island are on Medicare or Medicaid. And I'm afraid that's just not an option for many of our Ohana on the Big
Island. Adrian King asks, what effect did Obamacare have on prices? And why did the AMA support it? Basically, why did the AMA support Obamacare? It's a maybe a different question, but
I'm going to pass that one off to Dr. Dunham. I'm afraid that's above my pay grade.
I can tell you what it did to prices. I have no idea why the AMA supported Obamacare. It's, you know, I'm in New York, so New York is a little different than probably everywhere else, because if you have Obamacare insurance in New York, as my company unfortunately has to, you basically have no access to doctors at all because nobody takes any of the plans. So I think in terms of prices, what it's done is it's shifted most of those patients off to clinics and urgent care units. So it's really taken away business from doctors.
Another similar, oh, I'm sorry, Lisa, you had something to say.
Well, I was just going to say, I think that the Affordable Care Act, you know, they were hoping to improve access, obviously, and to be able to provide medical insurance for, you know, more people. And we've been successful in that in Hawaii and in a lot of the states because the Affordable Care Act allowed that. But, you know, the gains that from ACA and from expanding Medicaid in the last couple of years, still, it's basically stalled now in the last year. And so what was a great idea of everybody having medical insurance, it worked to some extent. But as I said before, when we were talking about healthcare here in Hawaii specifically, you can have insurance, but not necessarily have access. And you can be assigned to a physician, but if you only have 3 or 4 physicians in some area, you're still gonna have like 3-month wait to see your physician, you know, so that's not necessarily access.
Yeah, healthcare and health insurance are 2 different things.
Mm-hmm.
So
yeah,
I'd just like to mention the AMA represents about 12% of practicing doctors in the nation, most of whom are in academic practice, getting salaries from universities and hospitals. To look for them to be a voice of reason about what happens where the doctor hits the road out in the Main Street is erroneous. And they are frequently looked to be the voice of medicine. They shouldn't be.
I see. It's not all doctors are the same or in the same group, I suppose. Okay, the state seems to, Dwayne Lopez says, the state seems to have placed greater legislative support for advanced nurse practitioners in lieu of licensed physicians. How is this competition for services helping or hurting physician shortages? Is this keeping reimbursement rates low?
I could address that to some degree. Well, first of all, the APRNs who are functioning as primary care providers are a critical part of our healthcare network on the Big Island. If we did not have their assistance, you know, working with us, many times physicians and APRNs work together in the same practice, things would be much worse. As it is, many individuals, they don't have any access to primary care on the Big Island. And so what they do is they go to the emergency rooms. And so they go to the emergency room for things that could be managed in a primary care setting. And what that ends up doing is raises the cost of tremendously, because it can cost 4, 5, 6, 10 times as much to treat a medical problem in the emergency room as it would be in a clinic. And as been pointed out by Dr. Ignacio, once that person is treated in the ER and they need to be followed up on, there's no primary care provider at the back end to monitor therapy or to see how the patient's doing on their medication regimen or to see whether their pneumonia has actually been treated. So the way we're doing things right now is actually an extremely expensive way to practice. And as you probably heard in paying attention to this issue on the mainland, many times on the mainland, physicians, they take Medicare patients almost as kind of a charity care, expecting to break even or lose money on Medicare. But the local private pay insurance plans pay substantially more than Medicare, so they subsidize the overall cost and keep the practices open. In Hawaii, the level of reimbursement from private insurance is basically Medicare, you know, plus a % or 2. It's almost the same.
One more question. Joel Van Brunt asks, would Medicare for All help or hurt the shortage?
I'll already speak to that again. So if physicians, if we, in effect, with the GET, the county surcharges, we have the lowest Medicare reimbursement in the country. And so if physicians are already losing money taking care of Medicare patients, and then everyone was on Medicare, well, we'd all be out of business probably in 3 months.
I think another important point to that is that what is being called Medicare for All is actually not, because it gets rid of Medicare. All of the proposals for Medicare for All get rid of Medicare itself. So what it is really is Medicaid for all. And if I'm sure every doctor here can tell you how bad the reimbursement rates and the services are for Medicaid.
I should mention about Medicare and Medicaid that the way they decide what to pay is based on their political priorities. It's not based on the cost of delivering care. They figure out how much money can we take out of our budget every year, and then we're going to divvy it up from there. And how much money they take out has got nothing to do with how you actually deliver health care. It's logically divorced from that. And so to use Medicare as a benchmark for how you're going to do healthcare throughout the whole nation is ludicrous squared.
Okay,
Very
well,
good.
Go ahead.
Joe, thank you for moderating the questions, and to all of you who have participated with us today, we appreciate it. Thanks for the wonderful questions. And we've seen it. Hawaii's tax structure, particularly the GE tax, is driving Hawaii physicians out of local practice. And that's resulting in a shortage, a critical shortage of healthcare for Hawaii's people. I want to say mahalo to John Dunham, Ed Goodling, Elizabeth Ignacio, and Scott Grosskreutz. You did a great job today, panelists. Everybody, when you get off the line today, go to lethawaiiwork.com. Lethawaiiwork.com and sign the petition. Until next time, this is Keli'i Akina with the Grassroots Institute. Aloha.